A very good evening to all my respected viewers, my respected seniors, and all colleagues of today's CCI's webinar. Today, we are conducting the eighth webinar of the COPD series, which involves a lot of discussion on COPD, its future trends in terms of biologicals and interventional stuff. But prior to anything else, as a human being and as an Indian, today something very sad has happened at Ahmedabad, and sadly, a lot of human lives have been lost. And we are very sad to see that so many people, so many innocent peoples have lost their lives due to an accident. And I think it is our moral responsibility that we should pay a minute silence in their respect. On behalf of CCI, I would request all our viewers to keep a minute of silence in respect of all those victims who have lost their lives today. Om Shanti. On behalf of CCI, today, really, I find myself as at a loss of words and difficult actually to do webinar today. But it is the commitment of CCI to bring forth every Thursday at 8 p.m. its committed topic so that we further ourselves in this endeavor that our respected visionary leaders like Dr. Krishna, Dr. Narayan Pradeep, the entire webinar team has conceptualized. Believe me, this has come like a shock for everyone. And gathering ourselves and coming together for an academic effort, not only as you as viewers, but even we as faculty and panelists, is really something very difficult. But as a moderator, it is my responsibility to introduce you the panel which has worked hard for bringing this particular topic. I am glad that today we have a very special panel lined up for today's important webinar because it deals a lot to do with the future of how we are going to manage this disease, which involves the bread and butter of a lot of pulmonologists. The trends in pulmonology and the trends in COPD management are rapidly changing. And we today have with us several star speakers, star panelists, very knowledgeable group of pulmonologists. We have Dr. Kripesh Ranjan Sarmah from Guwahati. We welcome you. He is a pulmonologist at Apollo Hospital, Guwahati. We have Dr. Shyam Krishna from the east, from Kolkata, who is from CM Birla Hospital and Vayu Clinics is his initiative. He is a pulmonologist there. I welcome you, Dr. Shyam Krishnan. Then from the capital, we have our very own Dr. Harshvardhan Puri sir from Medanta, Gurgaon. And a big thanks to you, sir, for joining us to give your input on the surgical aspects, which are the really point of interest for a lot of people as to the future management of COPD. Then coming down south, we have Hyderabad contributing always as it does immensely to the future of pulmonology in India. We have two young and very dynamic speakers in the form of Dr. Srikar Darseity, who is a pulmonologist at Apollo Hospital, and we have Dr. Vishweswaran, who is a pulmonologist at Yashoda Hospital. Before I begin today's presentation and flow of academics, it is my duty to thank the webinar team, particularly Dr. CVK sir, Dr. Shivani, Dr. Atri, Dr. Narayan Pradeep, Krishna sir, Kirat, and lots of call out to them because see, while preparing for this topic, you really understand how things and perspectives in COPD management are going to change. To make it understandable, we'll be having talks by Dr. Kripesh, who will be talking on biologicals, followed by Dr. Vishweswaran, who will be talking about a lot of interventional pulmonology stuff, what we as pulmonologists can do with our bronchoscope in the COPD lung. And then Dr. Harshvardhan will be telling us ki bhai hat jao, the king has come. And then Dr. Harshvardhan Puri sir will be telling us a lot about the surgical aspects like LVRS, lung transplantation, because he comes from a very, very august team of chest physicians, and he'll be the best in the field to guide us about what the future beholds for us. So without taking up any more time, I would like to call upon Dr. Kripesh to come and give his presentation on biologicals.
Good afternoon, everyone. First of all, I would like to thank Chess Council of India for giving me this opportunity. So, over next 5 to 6 minutes, I am going to speak on biologics in COPD. So, precision medicine is evolving, and treatment based on precision medicine developed in recent decades have revolutionized certain natural course of many diseases. A therapeutic approach detected at individual characteristics of the patient substantially improve outcome with fewer side effects with precision medicine. In respiratory medicine, there is an extensive experience with use of biologics, particularly in asthma and lung cancer. But till that, there is no approved biologics for COPD. While predominant inflammation in most COPD patients are type 1 type, with neutrophil plays a predominant role. But 40% of patients of COPD may have overlapping feature with type 2 inflammation. Uh, that is shown by increased eosinophil count orchestrated by type 2 lymphocyte and innate lymphoid cell type 2. The mechanism of type 1 and type 2 inflammation may overlap in many COPD patients as demonstrated by predominant role of interleukin 13 in inflammation of patient of COPD asthma overlap, and asthma patient. So based on this inflammatory marker, there could be two phenotypes of COPD that can be targeted through biologics. One is your eosinophilic exacerbating phenotypes and the non-eosinophilic predominant neutrophilic phenotypes. So I'll go through this one of the significant impact of biologics in COPD has been shown in this clinical trial, which has been mostly discussed. This is a dupilumab for COPD with type 2 inflammation indicated by eosinophilic count, which is also in short known as BORIS trial. So in this trial, this was published just recently in New England Journal of Medicine. So this is a phase 3 double-blind randomized trial assigned patient with COPD who had a blood eosinophil count of more than 300 and elevated exacerbation risk despite of using standard triple drug therapy. And this group of COPD has been divided to receive a dupilumab or a placebo subcutaneous for once every 2 weeks. The primary endpoint was to annualized rate of moderate or severe exacerbation of COPD. And the secondary outcome are measured in terms of improvement in lung function, that is FEV1, the SGRQ questionnaire score, and evaluating respiratory symptom in COPD score. So the result, a total 939 patients are included in the trial, where 468 received dupilumab and 471 received the placebo group. The annualized rate of moderate or severe exacerbation was 0.78 in biologic group, where it is 1.1 in placebo group, showing a significant reduction in exacerbation rate by dupilumab in COPD patient. The pre-bronchodilator FEV1 increased from baseline to at 12 weeks by at least 160 ml in biologic group, where 77 in placebo group, showing a significant improvement, which is more than the targeted requirement. A 52-week SGRQ score has improved by minus 9.7 with dupilumab and minus 6.4 with the placebo. And the respiratory symptom score also at 52.6 weeks has shown improvement with the biologic. The number of patients with adverse event leading to discontinuation of the biologics or the placebo or serious event or advanced event leading to death were almost similar in both the groups. So this study concluded that among patients with COPD who had type 2 inflammation, as indicated by elevated blood eosinophil count, these who receive dupilumab has a fewer exacerbation rate, they have a better lung function and a better quality of life and lesser severe respiratory symptom than those who receive the placebo. Then this is a systemic review and meta-analysis of all the randomized control trial, which has a significant number of patients in relation to biologics in COPD. So this meta-analysis included study conducted at a systemic review of Medline, MBASE, and Cochrane Central for inception till July 2024 to identify a randomized control trial which involved biologics in COPD. They found 11 trials where more than 6,000 patients were included in the study. And the study included COPD patients of any severity or any baseline therapies. They included the biologics like IL-4 and 13 inhibitor like dupilumab, IL-5 inhibitors like mepolizumab, benralizumab, and resilimumab, and IL-13, IL-25, and TSLP inhibitors. So outcome of interest of this trial was annualized rate of moderate to severe exacerbation, change in lung function, change in disease-specific quality of life as measured by SCR2 questionnaire, and any serious event. So these are the summary slide of all the 11 trials regarding the, and all of them has patient of COPD where blood eosinophil count were quite on a higher side, with few of them has less than 300, but most of them has eosinophil count of more than 300. So the result is dupilumab reduces exacerbation rate as compared to placebo and as compared to other biologics with a high certainty of statistical certainty. Benralizumab and tepekimab and tezepimumab has also shown reduction, but this with a low certainty. So compared to all the biologics, dupilumab have shown a significant improvement in rate of reduction of exacerbation in COPD patients. So this is the forest plot where we can see the different role of biologics, and all of them has some improvement, but dupilumab has shown a very significant change in terms of a reduction of exacerbation in COPD. Then for all patients, there is no significant improvement in FEV1 has been shown by all the biologics. The target value was more than 1 liter, that is 100 ml. However, in patients, those who have blood eosinophil level more than 300, dupilumab and tezepimumab has shown a significant improvement compared to the other biologics. And also, dupilumab has shown a significant improvement in terms of SGRQ questionnaire. And so this meta-analysis concluded that dupilumab is effective at improving patient-related outcome in COPD with higher eosinophil level. And other biological therapies, including tezepimumab, has no important effect on patient-related outcomes compared to dupilumab. So the take-home message from these clinical trials on biologics in COPD is that biologics play a significant role in asthma. However, in COPD, the biological role are evolving, and it will be promising. Dupilumab in randomized control trial has shown promising result in COPD with where there is a high eosinophil count, which need more clinical trial for confirmation and future direction. Thank you.
Good evening, friends. I'm Dr. Vishweswaran. Today, I'll be speaking to you about the role of the interventional pulmonology in COPD. We all know that COPD primarily involves the small airway and also involves the alveoli of the lung. So essentially, it causes an inflammation, thickening of the epithelium, mucus plug formation, subepithelial fibrosis, and smooth muscle hypertrophy of the airway. All these things leads to airway obstruction, which causes dynamic hyperinflation, which causes the loss of elastic recoiling of the alveoli, and finally results in the classical COPD pathogenesis. When it comes to the management of the COPD, primarily it involves the medical management, but for severe cases of COPD, you can have non-pharmacological management, which can be in the form of the lung volume reduction, which can be done either in the form of surgery, bulectomy, or an LVRS, or it can be a bronchoscopic lung volume reduction surgeries like an endobronchial valve, coil, vapor ablation, or sealants. Apart from this, to target the airway, you can use a bronchoscopic method like a targeted lung denervation, or if you have a chronic bronchitis phenotype of COPD, you can use cryoablation, rheoplasty, in rare cases stenting, and if nothing works, then you go on to lung transplantation. So the idea about the lung volume reduction is from the National Emphysema Treatment Trial, which is a landmark trial, which basically classified the COPD patients into high-risk subjects and low-risk subjects. and people with low baseline exercise capacity and those with high baseline exercise capacity. When we say it is a high risk, we say that the patient is having an FEV1 less than 20% of predicted and either a homogeneous emphysema or a DLCO less than 20% of predicted. So if you see the graphs here, you can see that the probability of the death increased with the surgical management in patients in whom the lung volume reduction surgery was used, which essentially means if you have a patient who has got an FEV1 less than 20% or a DLCO less than 20%, then you should not be subjecting these patients for lung volume reduction surgeries. And the benefit that is associated with the lung volume reduction surgery, as you can see from the graph here, the probability of the death is decreased in patients who underwent lung volume reduction surgeries for patients who are upper low predominant phenotype with low exercise capacity, which essentially means your lung volume reduction surgery will only work for patients who has got a low, who falls under low risk and who should have an upper low predominant and a low baseline exercise capacity. If any other groups are used, like a non-upper low predominant or a high exercise capacity, then your lung volume reduction surgery did not result in a benefit in terms of survival. And if you see the graph here, even amongst the survival benefit, only people who were low risk and who had an upper low predominant and a low baseline exercise capacity showed an improvement with the lung volume reduction surgeries in comparison to the medical management. So we should limit our lung volume reduction, be it a surgical or a bronchoscopic, only for people who has got an FEV1 or a DLCO more than 20% and who tend to have an upper low predominant emphysema with a low baseline exercise capacity. But however, these surgical lung volume reduction surgeries also had certain degree of adverse effects, like 90-day mortality was little higher, and even air leaks were higher, pulmonary morbidity was higher, and cardiovascular morbidity was also higher. To overcome all these things, now we have less invasive lung volume reduction surgeries in the form of bronchoscopic lung volume reduction surgeries. These bronchoscopic lung volume reduction surgeries can be in the form of endobronchial valves or coils or thermovapor ablations or bronchoscopic other sorts of chronic bronchitis treatment like rheoplasty or cryotherapy and so on. So one of the most important aspects of the bronchoscopic lung volume reduction surgery are the use of the valves. We have two different valves, mainly the Zephyr valve as well as the spiration valve. The Liberate study is for the Zephyr valve and the Improve study is for the spiration valves. And based upon these studies, the FDA has cleared their recommendation for bronchoscopic lung volume reduction. So if you see the valves, this is how it really works like. So in a COPD, you got an hyperinflated chest, you got an increase in the residual volume and decreased in the exercise capacity. So what you do is you go inside with a bronchoscope, you place a valve. This is a one-way valve. So it allows the air to come out, but prevents the air from going inside the alveoli. Therefore, it causes gradual shrinkage of the lung, thereby decreasing the residual volume and increasing the lung capacity. But the problem with this is you need to obstruct multiple subsegments, and these valves may get clogged with mucus at a later stage and may become dysfunctional. And due to the sudden collapse of the distal airway, it can even cause catastrophic pneumothorax in certain patients. So if you see the study criteria for the Liberate valve and the Improve by the Liberate trial and the Improve trial, you can see that the FEV1 chosen were 15 to 45%. The TLC should be more than 100%, and your RV by TLC should be preferably more than 150 to 175%, and 6-minute walk distance should be at least 100 to 500 meters, and the percentage of the emphysema target lobe should be greater than or equal to 50%, and the heterogeneity is what is most important. So there should be a heterogeneous emphysema, and you need to use certain instrument called as a Chartis system to assess for the collateral ventilation. And if collateral ventilation is present, then probably your valves may not function effectively. And the primary outcome should be more than 15% improvement in the FEV1, and the duration of the study were 12 months in Liberate study and 6 months in the Improve study. And if you can see from here, when the endobronchial valves were used, the people with a FEV1 percentage more than 15% improvement was higher in the valve group in comparison to the control group. And even the change in the FEV1 was quite high in the valve group in comparison to the control group. And the 6-minute walk distance was higher in the valve group in comparison to the control group. And even there was an improvement in the SGRQ. And this is how you can see your MMRC improved, your board index improved, everything improved with your lung volume reductions with the help of your endobronchial valves. And even as you can see from here, this effect was sustained even at the end of 12 months, indicating that the valve therapy can have a sustained effect. And there was an improvement in the MMRC as well. So similar to this, there was another endobronchial collapse therapy which is available, which is called as the coils. So these coils are similar to the valves, help in causing the collapse of your emphysematous lung. But as you can see from the X-ray here, you need to use multiple coils across the segments, and thereby it brings about a reduction in the emphysematous lung and improves the lung capacity. But one advantage of using the coils over your valves is that the coils does not can be used even in cases of homogeneous emphysema. And as you can see from the picture here, there is an improvement in the 6-minute walk test, there is an improvement in the SGRQ, there is an improvement in the FEV1, and there's a decrease in the residual volume, indicating that the coils can be an effective therapy of bronchoscopic lung volume reduction. In addition to this, the people have even tried other simpler techniques like introducing a hydrogel foam, or even sometimes they have placed a spigots to cause the collapse of the emphysematous lung. But the problem associated with these techniques is that it can cause a higher incidence of a post-obstructive pneumonia, and that can lead to exacerbation of your COPD. So to overcome all these deficiencies which are associated with the endobronchial valves, there is another technique which is currently available in India, and luckily we are one of the very few centers in the country to have it, is what we refer to as a bronchoscopic thermovapor ablation. So basically, essentially what happens in this is, as you can see from here, whenever there is a COPD, there is an increase in the residual volume, there is a decrease in the pulmonary function, decrease in physical capacity and quality of life. Therefore, you use a bronchoscopic technique and thereby introduce a water vapor inside your airway and cause a chemical pneumonitis and cause the shrinkage of the emphysematous lung. This technique is what is referred to as a bronchoscopic thermovapor ablation. It is quite easy and procedure. Only thing is you need to have this dedicated instrument, and you need an approval from the US center based upon your CT scan to approve whether this patient can actually go for a thermovapor ablation or not. So what we do is, once we know there is a heterogeneity, we go inside with a bronchoscope, we introduce a balloon which has got a catheter with a balloon, and distal to that we introduce the water vapor, and this water vapor causes the chemical pneumonitis and it causes the shrinkage of lung. Unlike the valves and the coils, this will not produce an immediate effect. It causes a gradual volume reduction, thereby decreasing the risk of pneumothorax. But however, this takes little more time than the valves to actually perceive these effects. Therefore, it takes weeks before the lung actually shrinks in size. Therefore, the lower lobe expands, and therefore this brings about a decrease in the residual volume, and thereby improving the FEV1 and SGRQ and quality of life. And unlike the other techniques, this does not have any implants which are placed inside the lung, and therefore the complications of implants like hemoptysis and pneumothorax tend to be lower in thermovapor ablation in comparison to the valves. Apart from this, as we have seen earlier, for patients of COPD who have got a chronic bronchitis variant where there is an excess mucus production, we have certain techniques which is like targeted lung denervation. So basically what happens in this is you introduce a bronchoscope and then you introduce a catheter which has got a balloon, and this has got a radio frequency ablator. And therefore it radio frequency ablates this mucosa, submucosa and the neural layer, thereby bringing about a reduction in the parasympathetic activity, thereby decreasing the secretions and thereby increasing the bronchodilation. Apart from this, there is other techniques which are called as a rheoplasty. Basically, essentially what happens is in patients with a chronic bronchitis phenotype, you introduce these catheters and again you break down the goblet cells in the airways, thereby bringing about a reduction in the mucus secretion. And there are also certain studies which are working on the meter dose nitrogen cryospray, essentially to ablate the goblet cell layer of the airway, thereby decreasing the mucus production. But however, not all patients can benefit from the lung volume reduction surgeries. So if your patient is having an FEV1 or a DLCO less than 20%, and or he is not a candidate for LVRS because of homogeneous emphysema, or if he has got a very low board index of 5 to 6, or if his PaCO2 is more than 50 and the PaO2 is less than 60 millimeters of mercury, or if FEV1, as I said to you before, is less than 20%, then these are the patients who will actually benefit from a lung transplantation, which is already being extensively practiced in India. But if your board index is more than 7 and if your FE1 is less than 15 or 20 percentage, or if they have frequent exacerbations, then do not even think about lung volume reduction surgeries. Directly list these patients for transplantation. So I then like to end my presentation here, and this is my YouTube channel. If people really want to see the videos that we perform here, you can scan this QR code for it. Thank you for the opportunity.
नमस्कार। तो आज हम बात करेंगे रोल ऑफ सर्जरी इन सीओपीडी। आई एम डॉक्टर हर्षवर्धन पुरी। आई एम ए सीनियर कंसल्टेंट thoracic and lung transplant surgeon from Medanta. So COPD is a disease which has to be treated by a pulmonologist. We are very clear in that. So the pulmonologist is the Arjuna who has to treat this disease. But sometimes, like in the Battle of Mahabharata, this Arjuna has to be assisted by a Krishna, which in this case thoracic surgeon, to treat some kind of COPDs, which I will be telling in my presentation. So outline what surgeries, when to do and when not to do. So factors deciding surgery in COPD. It is clinical presentation of the patient, severity of symptoms, and overall fitness and lung function of that patient. So what are the indications? When the COPD is completely refractory, you have hit the wall, there is no more medical management you can do to this patient, or bronchoscopic managements have been all tried, and still the patient is having symptoms, we can consider surgery in COPD. And complications like bullous lung disease, rupturing leading to pneumothorax. So in these indications, please remember refractory dyspnea and respiratory failure despite all best medical managements. What are the surgeries available with us? LVRS, which is lung volume reduction surgery, and lung transplantation. So we'll be taking it one by one. Now, LVRS is reducing the lung volume by multiple wedge resections of the emphysematous areas, not of the bullas, of the emphysematous areas, where they are the most marked. So 20 to 35% of the lung has to be taken down by these wedge resections. It has a very old basically history that in 1959 Brengenton did clamp and suture method for emphysema, opening bulle and suturing for emphysema. Everything almost failed till the time a report from Mr. John Cooper came, which showed bilateral pneumectomy, not pneumonectomy, pneumectomy. He published this article. He showed very good results in emphysema. He showed a good percentage of FEV1 increase, exercise tolerance, and this report got him and made him an overnight sensation. It was published in almost all the newspapers of at that time, and it was taken as a breakthrough for patients of emphysema. It was known as Dr. Joel's Cooper volume reduction surgery, and it became an overnight sensation. But when his methods were being trying to be replicated in different centers, everything was not rosy. People showed bad results also by doing this lung volume reduction surgery. So there came a need to do a trial. Here comes the National Emphysema Treatment Trial, which was a multi-centric randomized controlled trial showing the primary benefits, primary objectives at survival in emphysema after surgery and maximum exercise capacity. The secondary objectives were to identify selection criteria for LVRS, effectiveness of the pulmonary function and quality of life, and assess the cost effectiveness. Something very, the inclusion criteria was screening enrollment, pulmonary rehabilitation, assessment, randomization into maximal medical therapy and lung volume reduction therapy. And 3 to 5 year follow-up, mortality, quality of life and function was to be assessed. So 17 clinical centers were taken. 1,218 patients were randomized. Screening was done in 3,777 patients. And with patients with no significant cardiac or pulmonary disease or hypertension were taken into the study. Now, all these patients underwent 16 to 20 sessions pre-randomization of pulmonary rehabilitation and 10 sessions post-randomization. And aggressive bronchodilator therapy was given to all. Surgical therapy, what was done was bilateral stapled resection of 25 to 30% of the lung. Now comes the catch of this study. 8 centers did only this surgery through a median sternotomy, and 6 centers did it with sternotomy and VATS, and only 3 centers did it with VATS. So when the preliminary results came out in 2001, they were devastating. It was clearly indicated in patients with emphysema who have low FEV1, this surgery should not be performed. Overnight, this also became a news that no, this surgery should not be done. This surgery should not be done, and they showed a mortality risk increase in surgery as compared to the medical therapy. Now, what happened was in 2003, they did a subgroup analysis of this study, and there came the real results of this study. So what they showed that medical therapy, the survival benefit is better than the surgical therapy, but when they divided into the surgical mortality to be 2.2% and the medical mortality to be higher in the long term, but in what particular patients I'll be telling you. What they divided was upper lobe predominant disease, lower lobe predominant disease, and improvement in exercise capacity after doing rehabilitation. So they divided into 4 groups. One was upper lobe predominant with low exercise capacity after after rehabilitation, upper lobe predominant with high exercise tolerance. So they showed that medical therapy in the first group, which is upper lobe predominant, low exercise capacity after rehabilitation, they fared very well with lung volume reduction surgery. And all the other groups, which are upper lobe predominant, high exercise capacity, non-upper lobe predominant, low exercise, or non-upper lobe predominant, high exercise, they all fared badly. So who should not get surgery? Let's talk who should not get surgery. If FEV1 is less than 20% of the predicted and there is homogeneous emphysema, no role of surgery. If DLCO is less than 20% and FEV1 is less than equal to 20%, no role of surgery. High risk patient, ECOG very poor, no role of surgery. So there is a very limited gamut and limit cohort of patient who should get surgery done in LVRS. What are the highest chances of surgical benefit? Non-high risk patients, upper lobe disease, and low post-operative rehabilitation exercise capacity. These are the patients who are going to benefit from this disease. Who are poor candidates? High risk patient, non-upper lobe predominant disease, and high post-rehabilitation exercise capacity. They should not be operated. Surgical procedure, it should be done in an acute center where a VATS is done. Median sternotomy or thoracotomy should not be applied for these patients like in our center. Unilaterality, it should be done unilateral followed by the other side or bilateral in the same now, what is the problem with the surgery? Air leak. So there are multiple methods of taking care of this air leak, like buttering suture, using of new staplers, Therapies machines to keep the lung expanded, forming a symphysis between the lung and the chest wall, by which these problems can be solved. LVRS is underutilized and a neglected surgery. I'll show you why. The 2001 report was a complete farce. They haven't done any subgroup analysis, but in 2003, when they did subgroup analysis, there was a role of LVRS in COPD management. Immediate media attention, I told you, was given. Lung surgery found to be ineffective. Surgery is a killer in emphysema. But what is the number of LVRS fell like anything in Southeast Asia as well as in US. So reason of underutilization, restricted patient access to a very small number of centers doing it, perception that surgery is very complex, lack of awareness that the therapeutic benefits of the operations are good enough in a particular set of patients, and discouraging results in these studies. So what are the misconceptions among physicians? It has got high mortality, high morbidity, high cost. Let's take down it into 3 points. Operative mortality of LVRS is less than 5%. 90-day mortality in most of the series is less than 5%. The overall morbidity is 40%. Most of it is air leak, which can be taken care by good stapling, good devices, buttress sutures, and these Therapies digital negative machines. The cost of the surgery, LVRS, is not high as it is perceived. The first year cost of surgery is much more than medical therapy. But when you compare the 3 years cost, the medical therapy is more costlier than doing a surgery. So what kind of disease you should be operating? It should not be homogeneous. It should be an upper lobe predominant disease with the patient going into rehabilitation therapy and getting the best benefit of LVRS. So how do we select cases for LVRS or transplant? If it is heterogeneous, it should be upper lobe predominance, low exercise tolerance, and non-high risk surgery. Go for LVRS. If it is a refractory disease, very low exercise tolerance, respiratory failure, and a homogeneous distribution of COPD, lung transplantation is the answer. Now you see this slide I've shown in most of the my presentations. Most common indication for lung transplantation worldwide, barring India, is COPD. So lung transplantation is a very good option for COPD patients where you have hit the wall. The criteria is chronic obstructive, most common indication. Referral for transplantation should only be considered in patients who continue to deteriorate despite optimal medical and surgical therapy. Bode index more than 6 should be referred for surgery. More than 7 to 10 should be taken for surgery. If there are multiple hospitalization for exacerbation associated with COPD, acute hypercapnia, PCO2 exceeding 50, pulmonary hypertension or cor pulmonale because of COPD, and FEV1 less than 20% or either DLCO less than 20% on homogeneous distribution of emphysema is an indication for going for transplant. So we have lot of gamuts of surgery available for COPD treatments. Our physicians have to trust us, but it should only be a combination of a chest physician and a chest surgeon who should be operating or managing these patients by doing a tumor board like thing, and we can reach the best optimal treatment for our COPD patient. And I rest my case. Thanks a lot.
Welcome back to all our respected viewers. A brilliant presentation by all our three panelists, really. Dr. Kripesh on biologicals, Dr. Vishweswaran on the bronchoscopic interventions, and Puri साहब आप तो श्री कृष्ण बन बैठे हम लोगों के लिए. But really well spoken. And you know the thing, I think what Dr. Puri sir's slide in the last told, and what he was telling, that we need to have trust. So trust is a big factor. And as far as discussion on futuristic therapies is concerned, you know, at times a pulmonologist oscillates in between being a new world person and an old world person. बार बार ऐसा लगता है यार कि सब कुछ ठीक ही तो चल रहा है, then why are you going in for all this change? Why this change? But all of us see some patients and we do realize that we have been treating them for years and still this guy is deteriorating, not meeting our fulfillment criteria, family is suffering a lot. Then definitely we should be able to offer something more to them tomorrow, today, in the near future. So let's come and discuss among all these leading pulmonologists as to what more we can do. This is one of the most promising webinars of this whole COPD series, because we are actually looking into that future where we can give you techniques which we have not followed. Most of us have heard, not done, but we all have studied it over the past few days and months to understand that yes, now they are a reality. So, Dr. Kripesh, you gave a very good presentation on biologicals. I would just like to ask you the current unmet needs in COPD treatment. Where do biologicals fit into this thing particularly?
Yeah, exactly. If you see COPD is in COPD there are lots of multiple mechanisms are involved in the development of COPD or in progress of COPD, and many a time we find that in spite of giving a proper bronchodilators or triple drug therapy of inhalers or other oral bronchodilators, also patient of COPD don't respond adequately. So in that case, definitely biologics has a role in selected patient. Where we can divide the COPD in a eosinophilic or non-eosinophilic inflammation, and where there's a high eosinophilic inflammation, most probably this group of patients will respond to biologics therapy.
So definitely identifying more phenotypes and subsets of COPD is going to take us places. But there are so many good anti-inflammatory presents, Dr. Kripesh. You have steroids, you have inhaled steroids, like you mentioned, SITT is there, phosphodiesterase inhibitors are there. Do you still feel that biologicals will be able to compare to these molecules?
Yeah, definitely. Because if you see, we cannot give a systemic steroid in a COPD for a long time. And also phosphodiesterase inhibitor also have certain limitation in long term their efficacy, and phosphodiesterase inhibitor has lots of side effects also. So if the patient is on a standard COPD therapy on a your inhaled medication or this phosphodiesterase inhibitor or other oral bronchodilator like theophylline also, if the patient don't respond and keep on worsening, in that case, or if the patient has asthma COPD overlap also, in that case also biologics has a roles to play.
Right, very well told. So, coming from Guwahati to Kolkata on the way back to Indore, where I live from, where I live in, well, tell me one thing, Dr. Shyam, like prescribing biological is a big deal. Like I practice in a place, I am not like Vishweswaran who will just start with biological in his prescription in the first prescription. We need to build it up. So, tell me, Dr. Shyam, are there any biomarkers in COPD? How we can make these biomarkers help us identify patients for biological prescription?
So it's a very good question. I mean, that endeavor has been ongoing, to develop that, the biomarker to detect COPD, like they did for cardiac conditions. But of late, I mean, COPD is a heterogeneous disease. It's there in the definition. So what happens when, you have multiple physiologies, pathologies going on? You have inflammation, you have tissue remodeling, you have oxidative stress, the multiple things going on at the same time. So, and all these pathological processes would generate some, interleukins, cytokines. So you have a plethora of markers as such. So it's very tough to develop one single biomarker for for COPD as such. Um, so that is an CRP and IL-6 have been studied, and they seem to have show variable associations with disease outcomes, and usually it is reproducible across different cohorts. But still, it's not. You can even have a high CRP levels. It's not specific for COPD per se.
Right. So
Uh,
then,
yeah,
please.
and most the biomarkers they don't have validation, so that is another issue. They lack validations. They cannot be reproduced across cohorts. That is one. So the I feel the heterogeneity and the lack of validation and the multiple etiologies which is going on, that contributes not having a specific biomarker. So now eosinophils are there, which we know that is a valid biomarker for at least for phenotyping patients. You can use it to phenotype into a eosinophilic or a neutrophilic phenotype, and then you can help the patient by starting on biologics.
Right. So means from what you answered in a very, very scientific manner, I, as a basic pulmonologist, can decipher that there is no single test on the basis of which we can advise a biological, and the most basic CBC, which has an eosinophil, is the best to prescribe the most advanced and expensive treatment, which is the biological. Right. So tell me, there is a lot of talk about these phenotypes, COPD phenotypes, or ये phenotype होगा तो that will alter the treatment discussion. Can you just tell us what are these COPD phenotypes?
So, like I mentioned before, it's been increasingly recognized that eosinophilic inflammation is one of the key players in, COPD pathogenesis, and it contributes to its progression. It contributes to airway remodeling. Uh, so we divide, and now since we have treatment to tackle the eosinophilic inflammation, it makes sense to phenotype patients, so that we can divert the patients into one cohort or the other. So you have an eosinophilic phenotype and you have a non-eosinophilic phenotype. That is the neutrophilic phenotype, where the inflammation is mostly because of a neutrophilic inflammation. So if you have an eosinophilic inflammation, it would be reflecting in your higher blood counts, and it is basically a surrogate for a T2 inflammation, and so that's where the biologics would work better. And in the neutrophilic phenotype, there you can consider, bronchoplasties. You can have therapies like, the interventions which Vishwesh and all that mentioned. You can consider those patients for vapor ablations, surgery if he qualifies, if he's a surgical candidate. And you can consider more of bronchodilator therapies rather than biologics.
So means first get the basic CBC done, then look at your patient clinically, divide him into eosinophilic or you divided him into a neutrophilic type. So taking things further, Srikar, tell me that lot of biologicals means lot of complex molecular mechanisms. What are these complex molecular mechanisms and how are these biologicals targeting?
Yeah. So these molecular mechanism, basically, we have got, like, if we go down to the pathophysiology, it's a combination of oxidative stress or reactive oxygen species, inflammation, imbalance between anti-protease and proteases, so defense failure of antioxidants, etc. So based on this, if we study the whole pathophysiology, we can make out several targets, the interleukin targets, and we'll be looking at biological molecules which target either the receptor or the epitope by itself. So based on that, we have got these particular molecules. So we have got different clinical trials starting off with dupilumab, which targets IL-4 receptor and IL-13 too, and mepolizumab, benralizumab, tezepelumab. So these particular molecules which have been discussed just now, out of which mepolizumab and dupilumab have been definitely, yes, they have been approved for eosinophilic COPDs, and most of them are in the phase 3 trial, the rest of them.
Right. So, like these biomarkers, which I was discussing with Dr. Shyam, he mentioned a few biomarkers. So,
Yes.
the selection of biologicals with biomarkers, are these two linked to each other?
Yeah, definitely. So starting off with the first two molecules which have got approved, that is dupilumab and mepolizumab, they particularly target type 2 inflammation in COPD. So we need to know our eosinophil count. I mean, we have to prescribe to those individuals who have a high eosinophil count. So that forms the cornerstone. Apart from that, of course, we need to marker the fractional exhaled nitric oxide, because that also does correlate with airway eosinophilia. Though, of course, it's not as validated as is it in bronchial asthma. Then IL-4, IL-5, IL-13 levels, once again pointing towards type 2. That's where dupilumab will be working on IL-4 and IL-13. And there are several other molecules, as sir has mentioned earlier, that which are not very specific. Whether it is IL-6 or surfactant protein D, fibrinogen, these are not really specific, and we can't call them a proper biomarker. You can have any of these alterations in ARDS or miscellaneous diseases. Of course, when we go down to the emerging techniques like transcriptomics and metabolomics and identification of single nucleotide polymorphism, for example, in the IL-33 variants. So this probably may actually help us distinguish distinct COPD subtypes. And thus, maybe when we go down to targeting the anti-IL-33 pathway, maybe this sort of advanced techniques will help us.
Amazing. Means so many nomics, all we heard here in practice mostly is economics. But okay, fine. You really means at least we're able to simplify this thing for the viewer audience as at large. Now one thing, पूरी साहब आप बिल्कुल बोर मत होना. देखो आखिरी में हम जो भी खिचड़ी पका रहे हैं वो आपको ही आके उसको पूरा वो करना है. And Vishweswaran, just hold on. I'll be catching you for all these bronchoscopic stuff. I just thought that it will have a little biological discussion first, and then I'll come on to you. So just bear with me for 10 minutes. Okay.
The boring stuff first, and then the interesting stuff.
Actually, biologicals might seem to be confusing, but I think when we discuss them, and particularly discussing with you guys, our aim is just to simplify the whole concept in COPD. Because in COPD, having biologicals in itself is, it's an amazing concept for many. अरे COPD में भी biological होता है क्या? देखो वो क्या कर. तो although it has come in the guideline, but still it is a big shift in the way that we think about COPD. So, Dr. Shyam, tell me one thing. You had referred to me about eosinophilic inflammation, and even Dr. Srikar mentioned about mepolizumab and some other things that are coming up. So, what is the relationship between this eosinophilic inflammation and response to biologicals in COPD in particular?
So, as you keep researching about eosinophils, they've been found to be the instigator for majority of the disease exacerbations. So, it started with bronchiectasis. I remember Professor Chalmers, he's a big name in bronchiectasis research. So they were actually looking at the neutrophilic, variant of bronchiectasis exacerbation. And then he happened to say that, under the electron microscope, they actually saw the eosinophils, which basically disrupts and generates granules, which then attract the neutrophils. So, which even we consider it as a neutrophilic inflammation is basically instigated by an eosinophil. So that's what they feel sometimes, even because certain studies show that even neutrophilic exacerbators tend to benefit with eosinophilic therapy. So probably one of the reasons it could be like the eosinophils are the major instigator for everything, but it's still not proved. So we need to stick to what we have as evidence. So eosinophilic inflammation definitely correlates with worsening in COPD, and especially the ones with where you have an asthma and COPD overlap. So those are the patients I feel definitely they would be having an eosinophilic exacerbation or eosinophilic inflammation, and that could benefit. And those cohort of patients would definitely benefit starting a biologic. And especially the mepolizumab is shown to have a good evidence, especially in reducing
So
excess.
that was exactly my next question. That see, either it be a monoclonal antibody against your interleukin 5, or could it be an interleukin 5 receptor blocker like benralizumab? This interleukin 5 therapy actually tells that we have to use it in patients who are having a asthma COPD overlap sort of situation. So, what is your comment on this interleukin 5 therapy in COPD, benefits and limitations?
So benefits are definitely there. So these studies, so there are limited studies, but whatever evidence has come out, it definitely shows that moderate to severe exacerbations are reduced, and the number of hospitalizations have reduced. Though the benefit in FEV1 or the lung function is debatable, but definitely the number of exacerbations are it's what they've demonstrated that it gets better if you use these therapies. Uh, we don't know. We need to see what mortality benefit it has, but it usually translates to that lesser number of exacerbations. Obviously, would translate to a better quality of life and better, lesser mortalities. So I feel it is pretty interesting, but I feel we can consider in patients whom we are basically pressed against a wall. We don't have much options to give, and if the patient does have that eosinophilic phenotype, I feel definitely it's worth trying.
Yeah, so it is what like it is, like it is still better than therapies like anti-TNF alpha infliximab, who when used in COPD exacerbations or moderate to severe COPD actually showed a higher incidence of malignancy and higher incidence of pneumonia. But it is better that way, ki kam se kam it is not increasing side effects.
Kind of. And
So
steroid sparing
now,
effect is there.
yes, sorry,
The
steroid
steroid
sparing
sparing
effect.
effect, so lesser chance of
Definitely, the
pneumonias.
biggest thing. So, since you came to steroid sparing effect, tell me, Shrikar bhai, this patient-related outcomes, like Dr. Shyam was touching on quality of life, symptom scores, do these biologicals actually come down to changing anything in terms of quality of life for the patient?
Yeah. So we'll talk about it in two different ways. One is how much of it has contributed to exacerbation reduction, which of these molecules. We'll talk only about the approved molecules for now, and how much of it has translated to improvement in lung function. Yes, definitely amongst these, we definitely do have a difference of opinions between the immunologic agents. Dupilumab definitely did improve health-related quality of life, and respiratory symptom burden also was reduced, as evidenced by trials like the Boreas and the Notice trials, though they are still in the phase 3. But not so with, benralizumab. Now, what could be the reason? Definitely, all these molecules have showed a reduction in the exacerbation frequency to the tune of maybe anything from 20 to 35%. But as we went higher up in the ladder, because dupilumab is one such molecule which is targeting IL-4 and IL-13 axis. So we are targeting a much upstream level. So in these people, we did observe a significant FEV1 improvement. So this, of course, as we have mentioned earlier, it is limited to a T2 inflammatory COPD who are already on triple therapy. And the other advantage with an IL-4, IL-13 suppression is you're going to actually reduce the mucus production, reduce the airway hyperreactivity, and reduce the remodeling.
So means we are actually, with the help of biologicals, targeting the pathophysiological mechanisms which make up COPD and worsen these COPDs eventually.
Yes.
But Shyam, tell me, with such a lot of anti-inflammatory and high-tech stuff going on, do they have any problem when there is a coexisting comorbidity, for example, like a cardiovascular problem in the COPD patient? Can we give biologicals in these cases? Unmute.
Yeah. So I feel, whenever there is a cardiovascular comorbidity is very serious in a patient with COPD. They always say in an exacerbation, the major cause of mortality is a cardiovascular instability or a cardiac failure or something which, triggers worsening of the condition and leads to mortality. So I feel it is the presence of a comorbidity. You can always consider giving a biologics because they've shown efficacy in reducing exacerbations. And though the safety, it hasn't been conclusively, proven that it worsens the comorbidity. But I feel if the presence of comorbidities, a cardiovascular comorbidity, better than trying drugs which have a side effect with cardiovascular comorbidity, you can always try this biologics.
Right,
so I feel it's safe to use.
Exactly. Now, tell me, Dr. Kripesh, one thing. Like we have talked about these, Dr. Kripesh, can you unmute yourself, please? Like we are talking about a lot of biologicals, and tell me, COPD biologicals, asthma biologicals. Can our treatment experience from asthma help us in COPD? Because asthma, we are using it biologicals far back.
Yeah, definitely, because whatever the trials showing benefit of biologics in COPD, these are almost the same biologics that are already been used in asthma patients for a long time. So if you see the this paper or meta-analysis that I have presented, where they have basically the most of the benefit are seen with IL-4 anti-biologics against IL-4 and IL-5 also to some extent. So where we can see that dupilumab is showing a beneficial effect in terms of improvement in lung function, in terms of reducing our exacerbation, and also some amount of benefit has been shown by mepolizumab also. So these are all the biologics that has already been actually in use in asthma patient and which has actually extrapolated in COPD patient.
And anyway, maybe you have cases like smoking asthmatics or asthma COPD overlap, then you are right in using the same biological in both these patients. Very right, Kripesh. Now tell me, Srikar, so what does the future hold for us? Up till now, in COPD, I'm using a bronchodilator, I'm giving a steroid, then suddenly changing on to biologicals. How will my treatment prescription or pattern be in the future?
So it's a very good question, because this is one thing which every patient is going to either ask us, or if we don't explain it, they're going to falsely assume. Just like how vaccinations, like example, if I say pneumococcal vaccine, I'm supposed to mention that it's targeting only the most common cause of pneumonia, that too to a significant tune in these serotypes. I cannot say that you'll never get pneumonia again in your life. So likewise, we have to make it very clear whether it's an asthma treatment or a COPD treatment. When we are using biologicals, we have to make it very clear that we are not providing immediate symptomatic relief. It is not like a relief inhaler, whether it's a smart therapy or whatever we call it. Unlike a bronchodilator, it is not going to immediately provide symptomatic relief. And also, we are only going to we are not going to have any sort of benefit from a biological as far as an acute exacerbation is concerned. We have to go back to our bronchodilators and steroids and rule out the other comorbidities as sir has just mentioned earlier. So targeted immunomodulator therapies are going to interfere with the specific inflammatory pathway, so they are going to provide long-term benefit via the effects against these key cytokines or the receptors, unlike the bronchodilators or corticosteroids.
So tell me one thing, Dr. Srikar, I won't leave you. Now, my patient's age as a COPD or my patient's smoking status, do you feel that that will actually decide as to when to advise which biological?
Okay, so now the thing is, we in all these clinical trials which we have talked about, or all these molecules before they are taken into the market, they choose the ideal population. So we would not be having a young COPD, we'll be having an ideal COPD patient, most of them who are aged more than 40 years, and also those who have a significant smoking history of more than 10 pack years, and they make it as a prerequisite. Just as sir has mentioned earlier, for the LVRS or any of these, we require certain criteria to pick up our patients. Now, as far as the data is concerned, elderly people, they respond in terms of lesser exacerbations but do not have much of spirometric gain for various other reasons, age related lung changes and smoking history. So you do have a difference in response based on whether the person is an active current smoker versus a smoking, whether he has adopted to smoking cessation. So ideally, even if we are giving these particular therapies for a smoker, it is always advisable to adhere to smoking cessation, and by this you will be potentially enhancing the biological efficacy. So trials is one thing, because we'll be deriving ultimately data for the trials. The ideal situation which is adopted in a trial cannot be mimicking our clinical response. So here, continuous smoking, there is data to show that continuous smoking may dampen the immunotargeted therapy. So, smoking cessation is pivotal. And also the critical predictors of treatment, such as biological markers like eosinophils and pheno, and also the high eosinophil count. So, before we prescribe these, we have to make sure that these particular biological markers and the fact that the patient doesn't smoke is definitely going to translate into better treatment response.
Right, right. Very, very well explained. You told it very well, actually, Shrikar. I see that you are being called to some emergency also in the side. So I immediately also would like to ask Dr. Shyam one point. Tell me one thing, Dr. Shyam. These biologicals, can they help us in preventing or slowing disease progression in COPD? Do you think it will be possible? Unmute, unmute.
So I feel most biological therapies which been studied, the primary benefit is to decrease the frequency and severity of exacerbations. So that actually translates to slowing down, because we know that with each exacerbation, the patient deteriorates, the clinically deteriorates, the disease progression happens, the lung function deteriorates. So if you can reduce the number of exacerbations and the frequency and the severity, you're indirectly preventing worsening. But improvements in lung function per se, I don't think so. They have demonstrated that significant improvement in lung functions, though. But at least we know that exacerbations are reduced, the quality of life scores are better, and that I feel translates to slowing down or reducing the progression of the disease.
Are there any benefits or risks of combining your biologicals with your COPD treatment? Is that there, or you can just give it anyway?
I don't think so. There are as such risks per se, but I haven't had my personal experience of prescribing a lot of biologics for COPD patients. But I feel, but there would be a synergistic effect. I feel like if you combine it with this, you can probably further reduce the exacerbation rates, or the risk of you might have a steroid sparing agent. You don't need to increase the dose of ICS, which probably translates to lesser chance of developing a pneumonia. Those kind of benefits you can have if you combine biologic with other COPD treatments.
So almost we're about to end our discussion part on biologicals because I see Vishweswaran and Dr. Puri are on the verge of running. So, but Srikar, one thing I'll tell you, I'll ask you rather, giving biologicals, will they help my COPD patient run better? Will they increase his exercise tolerance, physical activity?
So once again, the best results have been noticed with dupilumab for the the things which we had discussed earlier, because they are targeting upstream axis, that is IL-4 and IL-13, rather than going downstream. So these trials, especially the Boreas and the Notus trials, have showed an improvement in the SGRQ and also a meaningful enhancement in the patient's daily physical activities. And even though they did not consider 6-minute walk test as a primary endpoint, we can say that overall a 6-minute walk test would have improved because of subjective gains in symptoms and activity. And of course, it is to be reiterated that all these required prior use of standard triple therapy, which included inhaled corticosteroids. So we're going back to the same phenotype. We have to make sure that they're type 2 inflammatory patients. And also these all these molecules, at least 3 of them which have been approved, have reduced the frequencies of exacerbation, and have patients who are on that had fewer moderate to severe exacerbations and required lesser use of short-term oral corticosteroids.
Okay. Very, very brilliantly told. So I think all our three panelists have elaborated the role of dupilumab, mepolizumab, benralizumab, which are having somewhat of a role in COPD quite well. They have told us how they help us. But now there are situations where it becomes a problem, and even biological therapy doesn't help. So Vishweswaran, now I first would like to apologize you for keeping you waiting. But yours is a very important concept which I wanted everybody and to come at the peak of our webinar is that we image patients. We try to sit at an MDT. We have Dr. Harshvardhan Puri in our MDT. We have Dr. Shyam, Dr. Srikar, you as an interventional pulmonologist. But when we perform a CT scan, there are some few newer concepts which are coming in for treatment planning and looking at these COPD patients. Could you please highlight us these newer concepts which are coming in?
So basically, most of these lung volume reduction surgeries, like the bronchoscopic lung volume reduction, have come from the LVRS, which was the initial surgical data which we have. So based upon that, the first and the foremost thing when you look at a CT scan for a COPD is you need to see whether it is a homogeneous or a heterogeneous emphysema. So if you can grossly make out that it is predominantly one portion of a lung which is having more emphysematous region than the rest, it should not be like entire lung is homogeneous, then those are the lungs which will actually benefit. So if you have a heterogeneous emphysema, those are the lungs which is going to benefit. The second simple thing which you can easily look from the CT scan and make out is whether you have a fissural integrity or not. If you have a complete fissure which separates your upper lobe emphysema from a lower lobe, then possibly these are the cases where you can at least consider looking for a bronchoscopic lung volume reduction. Then third, in case if you have a bulla, the bulla should be not more than 1/3 of your lobar volume. Let's say that if you have a huge bulla which is causing almost the entire 1/3 of a hemithorax, then possibly these are the conditions where you will directly go for a bullectomy rather than even looking for a bronchoscopic lung volume reduction. But these are with respect to the routine assessment of your CT scan. But apart from that, the most important newer innovations in the CT scanners, we call something called as a heterogeneity index. So this is a quantification of your emphysema. We call it as the voxel units. So you actually quantify your emphysema. Let's say that an emphysema is normally is minus 910 Hounsfield units. So you calculate this emphysematous region. And if you find that in one lobe of a lung, the emphysematous region is much higher in comparison to the adjacent lobe. Let's say that I have a right upper lobe. I calculate the emphysema index in that, and I calculate the emphysema in the right lower lobe and middle lobe. And if this heterogeneity index is more than 1.2, so then we consider these patients to be the cases where we can consider where the success of LVRS is going to, bronchoscopic lung volume reduction is going to be high. So these are the certain parameters with respect to emphysema, but you should not limit your CT scan only to looking into emphysema. Let's say that a patient comes to you with a severe COPD and you find a disproportionate pulmonary hypertension. then probably these are the patients who are not actually suffering from COPD. They are suffering from a coexistent severe pulmonary hypertension, which needs assessment and treatment. And second thing is, let's say you have a CPFE patient. That means you have an upper lobe emphysema and you have got ILD in the basal segment. Then these are the patients who are not going to benefit from your lung volume reduction. So you need to have a composite assessment. And only when you have a heterogeneous emphysema, then probably most of these lung volume reductions are going to work. Another important thing not related to radiology is you need to see the patient as a whole. It is not that you see the CT scan and you start thinking about lung volume reduction. For example, if patient has very frequent exacerbations, or patient is already moribund, or patient is already on an oxygen, or if you have a PaCO2 value more than 50 millimeters, or patient is already oxygen dependent, then these are the patients actually will not benefit from a lung volume reduction, because we get a lot of, since we have a thermovapor ablation at our center, we get a lot of referrals for patients for bronchoscopic lung volume reduction. But unfortunately, when they come, they already have a DLCO less than 20%, FEV1 less than 20%, or they are in acute exacerbation, already into type 2 respiratory failure, or already hypoxemic on oxygen therapy. Then if you really do a thermovapor ablation in these patients, then they will not benefit. So you need to not only look into the CT, you need to look into the patient as a whole, and then decide whether actually it will bring about meaningful change in their outcomes or not.
Very, very well answered, Vishweswaran. matlab, you made it crystal clear, gave a lot of insight into not only the CT but looking to the patient as a whole, which is the most important point. Now, you touched upon a lot of patients being referred to you for bronchoscopic thermo vapor ablation. So, just tell me, you told me when people get it wrong, but when is it right to refer the patient for bronchothermic BTVA basically?
So basically, whenever we do all these lung volume reduction surgeries, we need to have what is the outcome of the procedure. The outcome of the procedure is reduction in dyspnea and improvement in the quality of life. Only for these two things we are going to do for this lung volume reduction for any patient. So when a patient, the ideal patient would be a patient who has still not gone into long-term oxygen therapy and who doesn't have an decompensated type 2 respiratory failure, and patient who didn't have an immediate exacerbation. So generally what happens is when the patient is on NIV or the patient is on a ventilator, the patient, if you send for a lung volume reduction, these are the patients who cannot be offered bronchoscopic thermovapor ablation. Second, the FEV1 should be at least more than 25%. We say at least 25 to 40%. And the DLCO should be more than 20%, which essentially means you are seeing a patient of a COPD who is troubled by his dyspnea despite maximum medical management and who is prone to develop future exacerbations. So that is the patient whom ideally should be subjected for a lung volume reduction surgery. Unfortunately, many a times when we receive, the patient is already on an oxygen, the patient is already frail, morbid, or patient on a ventilator. Those are the conditions you should not be doing the procedure. And once you decide to do a procedure, then it should also be noted that post-procedure, the patient can be at a risk of exacerbation. So they should be ready to anticipate these exacerbations and report immediately. So I think if you find a patient on COPD, you started a triple drug therapy and you put on long-term azithromycin, patient dyspnea not improving and prone to develop future exacerbations, before they land up in an exacerbation, these patients should be ideally sent for lung volume reduction assessment.
Right. So means very simply put, can I say, is it the time to think about bronchoscopic intervention in early stage COPD? Can I say that, or that is a little bit too early actually?
Early would be too early. Maybe group D, when you assess your patient and put you under group E. Now we don't have D, so you put it under group E, and patient is still getting troubled with dyspnea, then send this patient for assessment. Those will be the ideal patients.
Right. So now I'll have a rapid fire in between Dr. Puri Saab and Dr. Vishweswaran. Like just simple questions. But before that, Dr. Puri sir, let's make life simple. Like, after hearing to my three biological panelists, my Vishweswaran sir, now अब ये समझ में नहीं आ रहा है कि अर्ली सीओपीडी को किस डायरेक्शन में जाना है. बट हम ये तो समझ सकते हैं ना कि लेट सीओपीडी आपके पास भेजना है. इज इट ट्रू? टेल मी विच इज द आइडियल पेशेंट यू वुड लाइक कि यार रवि तूने ये पेशेंट भेजा, इसका सर्जरी करूंगा, मजा आ जाएगा. टेल मी प्लीज.
मैं आपको I'll tell four conditions, four situations where a thoracic surgeon is of help to a chest physician in COPD. The number one is when your patient has hit the wall and there is a homogeneous distribution of heterogeneous distribution of emphysema, and his exercise capacity after maximum rehabilitation is not increasing. Then, if it is an upper lobe predominant disease, LVRS should be considered very safely, but in a center which does LVRS regularly, not centers who are doing thoracotomies or median sternotomies for that, maybe a bilateral VATS. That's one situation. Situation two is when your COPD patient has a bulla with COPD. It's a huge giant bulla, multiple bullous disease. Yeah, the volume of the lung which is suppressed because of that bulla, we do a bullectomy on that patient. The FEV1 increases. We are helping the chest physician a lot in that. Third situation is when these patients develop secondary spontaneous pneumothorax. Now the patient develops pneumothorax, you put in an ICD, the lung is not expanding. We have a whole gamut of ICS protocol, how we manage these patients. We admit them, we give all kinds of medical therapies to them, apply a good negative suction, which is an ambulatory negative suction, put them on rehabilitation therapy, see the lung expansion, go in by VATS, seal the area of air leak, put talc and do a talc fluoridesis. And the fourth condition is when we have a homogeneous distribution of emphysema, your medical management has completely hit the wall. Now the patient is deteriorating. His only organ of involvement is lungs. He is less than 70 years of age. His ECOG is okay. And you seem to develop a mechanism by which you can improve his 6-minute walk test and ECOG like rehabilitation. These patients should be under consideration for a lung transplant. So these are the four conditions in COPD where a lung transplant surgeon or a thoracic surgeon is of help to a physician. I always say that COPD has to be treated by a physician. But whenever the physician is in trouble, please call us.
वेरी वेल पुटेड सर. बड़ा क्लियर कट काम है, मजा आ गया. सर्जन जब क्लियर बात करता है ना तो लाइफ में इससे अच्छा कुछ भी नहीं लगता है सर. आई एम टेलिंग यू. बट टेल मी विश्वेश्वरन सर टोल्ड मतलब homogeneous emphysema surgeon, is that it? Bronchoscopic intervention, nothing in homogeneous emphysema?
So actually if you see the guideline also, when you have a homogeneous emphysema, generally most of this lung volume reduction actually fails, but coils have been tried in homogeneous emphysema, one. Second, let's say that patient is having a homogeneous emphysema, but patient is also having a severe bronchitis variant, where he is troubled not by emphysema, but he is troubled by chronic mucus production. Then these newer technologies like targeted lung denervation, or you can even try a bronchial rheoplasty or even a spray nitrogen cryo. So these are the techniques which are coming up for bronchitis variant of a COPD. So despite you need not even look into homogeneous or heterogeneous, you can just see that if they are troubled by the symptoms of excessive mucus production, then these sort of interventions can be tried. But in general, heterogeneous emphysema would be the ideal candidate. That too predominantly in upper lobe heterogeneous emphysema would be the ideal candidate for most of these bronchoscopic lung volume reduction surgeries. Homogeneous, certain cases where you put coils on both the sides can still be tried, but not advisable. Mostly it's heterogeneous.
So heterogeneous, bronchoscopic, homogeneous, Puri sir. Now tell me one thing. Kripesh bhai, you are sitting in Guwahati, or Dr. Shyam, I want an opinion from both of you. When will you send a patient of COPD for lung transplantation? I want a very practical answer. I don't want an academic answer. Kripesh first.
Yeah, sure. If the patient on optimal medical management still having a frequent exacerbation, so I feel those are the ideal candidate for lung transplant.
Shyam, when will you send it for lung transplant?
So, so I mean, it's a very fine line between, prolonging the duration, and then once you reach a very terminal stage, the patient is almost unfit for surgery also, and then you send him to a surgeon for a transplant, the outcomes are going to be poor. So that is what we have to, balance that. I feel you have to discuss with the patient at early stages itself, and you discuss with him, try all the non-pharmacological therapies, whatever is available, extensive rehab. Uh, then you, if the patient is, improving with that, fine. Not improving, have a discussion with him. And these are basically for patients whose, whose lung functions are really poor. They're almost wheelchair bound, cannot even walk a couple of steps. Those are the patients I would, not develop very significant pulmonary hypertension. I wouldn't wait till they develop very high pulmonary hypertension and all that. And I would always try to evaluate when they're slightly better off, and then you need to sit and discuss with them. Uh, what would they like to have? And same
So
with, even bronchoscopic methods. The problem with vapor ablation is there's a very high exacerbation rate. Almost the literature says up to 30% exacerbation rates can be experienced in the first 2 to 3 weeks. So that is a gamble you always take with bronchoscopic methods, uh, especially vapor ablation. Uh, but transplant, I feel, is very underutilized, especially for COPD patients. I feel the awareness should be more. And I feel we should sit with the surgeon, develop a protocol as to when he would also be comfortable, accepting patients. Now it's usually that when we have totally given up, we refer him to the surgeon, and the surgeon is like, what do I do with him now? With such poor lung function, and the patient is a poor surgical candidate anyway, outcomes won't be great.
right. So maybe patients with I Vishweswaran, I may be wrong, but tell me, is a poor lung transplant candidate a good candidate for a bronchoscopic intervention?
Definitely not. So it is like a bridge. So where you are exactly leading to, maybe once your lung functions have gone so bad that it is less than 20 percentage, no option. You have to go for transplant. So between 20 to 40, where your medicines are not working, is the ideal candidate for your lung volume reduction. So anyway, patient who has got an FE1 more than 45 will not be that symptomatic going by the PFT. So medical management. So FE1 and DLCO more than 40 percentage and not so symptomatic, continue medical management. Between 20 to 40 percentage, going more towards symptomatic, consider lung volume reduction. Anything which is less than 20 percentage, go for transplantation. So that would be the simple way of
So
putting it.
Puri sir, believe me, the final word will be yours. But Dr. Srikar, are you with me?
Yes, sir.
Yeah, so Dr. Srikar, just one thing I want to ask you. One very interesting graph Dr. Puri sir told that the biggest referral for lung transplantation in India is actually COPD. But tell me, in your practice, you would be more eager to refer a COPD patient for a transplant or an ILD patient for a transplant? The practical aspect of referring for transplant.
So here, I mean, it's a difficult question to answer because I would definitely, because I have more options as far as the COPD patient, as we have discussed all along now, we have bronchoscopic interventions, but I don't really have much of an option for an end stage ILD patients. You don't have really good antifibrotics, nothing is going to reverse. So here, as far as referring is concerned, and I can't really say that one is better than the other, but an ILD case I'll definitely refer to, sir. There's no doubt about it because of the rapidity of decline, especially progressive pulmonary fibrosis, where our treatment options are limited. COPD, we still have, I won't say exactly a cafeteria approach, but we do have some different phenotypes, and if we have homogeneous or heterogeneous, I do have different options which you can offer to the patient until, as Dr. Vishwesh has mentioned, wherein the FE1 and DLCO drops to below 20%.
So I have a patient which Dr. Puri's team treated fabulously. So it's a middle-aged, not middle-aged, late 50s, early 60s, heterogeneous emphysema, big, and along with a very large bulle. And the FEV1 was somewhere hovering around 20-21%. They did a wonderful job they did a bullectomy. She's doing really fine post, been almost a month or so post surgery, or 2 months, I guess. They're doing really well. So those are the cases which, and this patient had a pulmonary PASP of 51, 52. So they did a good rehab pre-op, reduced the pulmonary pressures, increased her exercise tolerance, and then went ahead for a bullectomy a month or so later, and the patient touchwood is doing well. So I feel the timing when you refer and the surgeon's confidence, whether they can do it or not, I feel that matters.
Right, right. Very well told. So, like I told Puri Sahib, see, the last word is always the surgeon. See, I always believe that even in pulmonology, now that is how things are becoming. So, Puri Sahib, you heard all of us speak, but tell me, आप एक एडवोकेसी करो इस सर्जिकल अप्रोच इन सीओपीडी के फेवर में. डू यू फील कि ओवरऑल आउटकम बेटर रहेगा? डू यू फील कि कार्डियोवास्कुलर रिस्क कम रहेगी? डू यू एक्चुअली एज अ सर्जन फील दैट इन सीओपीडी surgery is a good option?
One disclaimer: the slide I showed of transplants it is a worldwide slide. Worldwide, the COPD is the number one transplant indication. In India, it is not even maybe 20% of the transplants are not being done by COPD. For COPD, there are three answers to that. One is COPD patients have a cafeteria of treatment as told by all my fellow people here. They have biologicals, they have bronchoscopic methods, they have rehabilitation. So it is more of a considered in India. It is considered more of a lifestyle disease. So patient चलता रहता है इन सब चीजों के साथ and is referred very late for transplant where we can't do anything. So in India, most common indication always is ILD. The situations in COPD where I am 100% I will help a physician is when it is completely homogeneous. The FEV1 is below 20%. He's a well-preserved patient. Transplant is going to help the patient immensely. Second thing, a bullectomy, like Dr. Shyam has told, very difficult patient. She has developed PH also. We did a lot of rehabilitation therapy, lot of anti-PH measures, and then operated. Excellent results. And LVRS in a very particular subset of patients, completely homogeneous disease, bilateral, extensive upper lobe involvement, and the patient is not improving with maximum rehabilitation therapy, the surgeon is going to help the physician a lot. See, what we need in these patients, we need these patients to lead a good quality of life. We need these patients to be maybe not off drugs, but be on minimal drugs and do their daily activity, maybe their financial activities also. The patients ask us when I'll be able to resume my financial things and all those stuff. So the answer has to be given. This answer cannot come from a pulmonologist. This answer cannot come from an intervention pulmonologist. This answer cannot come from a thoracic surgeon. It has to come from a good MDT kind of a thing where all three people sit together. The pulmonologist say, I have this biological to treat him. The intervention pulmonologist says, I have this bronchoscopic method, and a surgeon says that I have this surgical method, and we tailor it according to that single patient, and truly saying we'll have best of the results in COPD.
Very, very well told. Very well told. That is why Dr. Puri sir is always the showstopper. So now we have brought the future of COPD to CCI and the doorsteps of all our colleagues and seniors. I would like a closing remark from all of my panelists as to the future of COPD. What is your opinion, and in what would be the best interest of our patient? I would like to begin with Dr. Kripesh.
Yeah, so I think we have lots of treatment options available for COPD now. So we have to customize according to the COPD phenotypes or the underlying disease or the disease progression or the stage of disease or disease severity. So accordingly, we have to select the patient and we have to optimize the treatment. So some of the patients who are very severely ill, they may be a good candidate for lung transplant. But in between, those who are moderately seeing, they can go for a different in bronchoscopic intervention. And then those who have eosinophilic inflammation associated with COPD, they may be a candidate for biologics. So, so now we have a different options, and we have to customize according to the patient's phenotypes.
Very well said. Now, Dr. Shyam, your final comments, please.
So I feel phenotyping the patient of COPD is very important. I feel you consider everything like an obstructive airway disease, and then phenotype accordingly and treat the phenotype. That is very important. And in the future, I feel there is this lot of work on inflammation, like we talked before. There's a lot of work, studies on the microbiome of the lungs, which is happening. So they feel COPD could be related to, the constant interaction between the different bacteria and the viruses or whatever the ohms which are there, the different biomes which are there, and they interact and they keep creating this inflammation. So you have anti-inflammatory, especially in bronchiectasis, you have drugs like brensocatib, which is coming. So we might have something like that in the future for COPD. And if that works, you never know. It could change the direction.
So Srikar keeps on telling about nomics, and you are now telling about gnomes. So it is getting very, very grammatically difficult also. So Dr. Puri साहब, यहाँ पे आपको शो स्टॉपर नहीं रखूंगा. यहाँ पे मैं एक क्वेश्चन भी शेयर करूंगा आपसे. Dr. Toke, my friend from Pune, is asking role of surgery in TOPD with recurrent hemoptysis. तो मतलब post COPD with recurrent hemoptysis. Any role of surgery in this particularly?
If a cavitatory lesion is there, obviously we can resect it. And minimal surgery in that case may be a segmentectomy, maybe a non-anatomical wedge or a lobectomy. Not more than that.
Great. And Puri sir, your final comments, please.
Sir, always a MDT for all the patients, whether they are oncological or non-oncological, particularly COPD, and believe your thoracic surgeon.
Right. So, Dr. Vishweswaran, tell me your comments. You very beautifully elucidated the CT and overall picture of the bronchoscopic scenario in COPD. Your final comments, please.
So I think we should start seeing the patient as a whole rather than just looking into the CT scan for any sort of intervention. And as everybody said, that always think about non-pharmacological therapy, because in a busy practice, apart from inhaler, we don't think anything. So we need to think about the role of surgery. We need to think about role of non-pharmacological therapies like rehabilitation, vaccinations, and even bronchoscopic modalities and other things. So.
Thank you. And Dr. Srikar, our showstopper for the day, your final comments on the future of COPD management.
So, despite having exciting new terminologies or molecules, it's always important for us to go back to the basics, confirm the diagnosis, assess severity, and also have a clear exacerbation history, phenotype the patient, utilize the markers. Since most of your biologicals are based on type 2, try to assess it early. Of course, do pick up the frequent exacerbators and also try to identify the rapid decliners and who are comorbidity driven, so that you know which therapy will offer best benefit. We should not utilize our best equipment for, just like if you're at the border, you just won't go bombing the border just because you have your advanced technology. Okay, that would be disastrous. So we know when to act. And once we have adequately phenotyped the patient, we know when to refer for a bronchoscopic intervention. When do you start using biologicals, and most importantly, as Puri sir has mentioned, when do you refer it to a surgeon, so that you're not too late in giving the apt benefit to a patient.
That said, I would like to extend a big thanks to all my panelists for participating in this very, very important and I would say a benchmark discussion on COPD. It will be uploaded on our CCI YouTube channel also. And I would like to say that COPD is actually preventable if you stop smoking, treatable, and the future beholds a lot for all our COPD patients, but still maybe more stronger work on smoking and pollution will help us have simpler COPD patients to treat and not need such a lot of complexities. But if they do arise, then we have gone through biologicals, bronchoscopic interventions, and surgery also with this elite panel. On behalf of CICI, I would like to wish all of you a very, very good night and a big thank you.
Thank you. Thank you.
Thank
Good
you.
night. Thank you.